Okay, this is chapter 15 of the Mental Health ATI Psychotic Disorders. If you found that my recordings have helped you in any way, please share them with other students to maybe help them along the way as well. So, schizophrenia, spectrum, and other psychotic disorders affect thinking, behavior, emotions, and the ability to perceive reality. Schizophrenia probably results from the combination of genetic, neurobiological, and non-genetic injury at birth and viral infection and nutritional factors. The typical age at onset is mid-teens and mid-20s, but schizophrenia has occurred in young children and can begin in later adulthood. A predominant period can occur during the client's experience negative symptoms, which is anergia, or reduced level of positive symptoms. Psychotic disorders become problematic when manifestations interfere with interpersonal relationships, self-care, and ability to work. Types of disorders. The various types of psychotic disorders recognized and defined by the DSM-5-TR include the following. Schizophrenia. The client has psychotic thinking or behavior present for at least 6 months. Area of functioning includes school or work, self-care, or interpersonal relationships are significantly impaired. Schizotypal personality disorder. The client has impairments of personality, self, and interpersonal functioning. However, impairment is not as severe as with schizophrenia. Delusion disorder. The client experienced delusional thinking for at least 1 month. Self or interpersonal functioning is not markedly impaired. Brief psychotic disorder. The client has psychotic manifestations that last 1 day to 1 month in duration. Schizophreniform disorder. The client has manifestations similar to schizophrenia, but the duration is 1 to 6 months, and social occupational dysfunction might not be apparent. Schizoaffective disorder. The client's disorder meets the criteria for both schizophrenia and depressive or bipolar disorder. Substance medication-induced psychotic disorder. The client experiences psychosis due to substance intoxication or withdrawal or after exposure to or withdrawal from a medication. However, the psychotic manifestations are more severe than typical expected. Psychotic or catatonic disorder due to another medical condition. The client exhibits psychotic features such as impaired reality testing, bizarre behavior, which is psychotic, or a significant change in motor activity behavior, catatonic, but does not meet criteria for diagnosis with another specific psychotic disorder. Assessment. Characteristics, dimensions of psychotic disorders. Positive symptoms. These are manifestations of things that are not normally present. These are most easily identified manifestations. Hallucinations, delusions, alterations in speech, and bizarre behavior. Walking backwards constantly. Negative symptoms. Absence of things that are normally present. These manifestations are more difficult to treat successfully than positive symptoms. Affect, usually blunted or flat. Alogia, poverty of thought or speech. The client might sit with a visitor but only mumble or respond vaguely to questions. Anergia, lack of energy. Anhedonia, lack of pleasure or joy. The client is indifferent to things that often make others happy, such as looking at beautiful scenery. Avolition, lack of motivation in activities and hygiene. For example, the client completes an assigned task, such as making their bed, but is unable to start the next common chore without prompting. Cognitive findings. Problems with thinking make it very difficult for the client to live independently. Disordered thinking, inability to make decisions, poor problem-solving ability, impaired abstract thinking. Affective findings. Manifestations involving emotions, hopelessness, suicidal ideation, unstable or rapidly changing mood. Alteration in thought, delusions. Alterations in thought are false fixed beliefs that cannot be corrected by reasoning and are usually bizarre. These include the following: ideas of reference, misconstrues trivial events and attaches personal significance to them, such as believing that others who are discussing the next meal are talking about them. Persecution, feels singled out for harm by others, such as being hunted down by the FBI. Grandeur, believes that they are all-powerful and important like God. Somatic delusions, believes that their body is changing in an unusual way, such as growing a third arm. Jealousy, believes that their partner is sexually involved with another individual even though there is not any factual basis for this belief. Being controlled, believes that a force outside their body is controlling them. Thought broadcasting, believes that their thoughts are heard by others. Thought insertion, believes that other thoughts are being inserted into their mind. Thought withdrawal, beliefs that their thoughts have been removed from their mind by an outside agency. Religiosity is obsessed with religious beliefs. Magical thinking, believes their actions or thoughts are able to control a situation or affect others, such as wearing a certain hat makes them visible to others. Alterations in speech. The following examples can occur: associative looselessness, unconscious inability to concentrate on a single thought, can progress to flight of ideas in which the client's speech moves so rapidly from one thought to another that it's incoherent. Neologisms, made up words that have a meaning only to the client. I changed and flitted, for example. Echolalia, the client repeats the words spoken to them. Cling association, meaningless rhyming of words often forceful, such as ox, fox, obox, and lox. Word salad, words jumbled together with little meaning or significance to the listener. Hip hooray, the flip is cast, and wide sprinting in the forest. Circumstantiality, including multiple and unneeded details during a conversation, such as describing in great detail the weather and clothes they are wearing when asked what their plans are for the day. Tangentiality, starts talking about trivial information rather than focusing on the main topic of conversation, such as talking about what they will have for lunch when the discussion is about discharge medications. Alterations in perception. Hallucinations are sensory perceptions that do not have any apparent external stimulus. Examples include auditory, hearing voices or sounds. Command, the voice instructs the client to perform an action to hurt self or others. Visual, seeing persons or things. Olfactory, smelling odors. Gustatory, experiencing tastes. Tactile, feeling bodily sensations. Personal boundary difficulties. Disenfranchisement with one's own body, identity, and perception. This includes the following: depersonalization. It's a non-specific feeling that a client has lost their identity. Self is different or unreal. Derealization. Perception that the environment has changed, such as the client believing that the objects in their environment are shrinking. Illusions. Misperceptions or misinterpretations of a real experience. Alterations in behavior. Extreme agitation, including pacing and rocking. Stereotype behavior, motor patterns that had meaning to client, sweeping the floor but now are mechanical and lack purpose. Automatic obedience, responding in a robot-like manner. Waxy flexibility, maintaining a specific position for an extended period of time. Stupor, motionless for long periods of time, coma-like. Negativism, doing the opposite of what is requested. Echopraxia, purposeful imitation of movements made by others. Catatonia, pronounced decrease or increase in the amount of movement. Muscular rigidity or catalepsy may be so severe that limbs may be severe that the limbs remain in whatever position they are placed. Motor retardation, pronounced slowly of movement. Impaired impulse control, reduced ability to resist impulses. Gesturing or posturing, assuming unusual or illogical expressions. Boundary impairment, impaired ability to see where the person's body ends and another begins. Standardized screening tools. Abnormal involuntary movement scale. This tool is used to monitor involuntary movements and tardive dyskinesia in clients who take antipsychotic medication. Nursing care. Milieu therapy is used for clients who have psychotic disorder both in acute mental health facilities and in community facilities. Provide a structured, safe environment for the client in order to decrease anxiety and to distract the client from constant thinking about hallucinations. Assertive community treatment is intensive case management and interprofessional team approach to assist clients with community living needs. Promote therapeutic communication to lower anxiety, decrease defensive patterns, and encourage participation in the milieu. Use appropriate communication to address the hallucinations and delusions. If the client is experiencing command hallucinations, provide for safety due to the increased risk for harm to self or others. Determine discharge needs, ability to perform ADLs. Perform self-care by modeling and reinforcing teaching about self-care activities within the mental health facility. Provide teaching regarding medications. Whenever possible, incorporate family in all aspects of care. Client education. Develop social skills and friendships, participate in group work and psychoeducation, comply with the medication. Medications for psychotic disorders. Schizophrenia spectrum disorders are the primary reason for the administration of antipsychotic medications. The clinical course of schizophrenia usually involves acute exacerbations with intervals of semi-remission in which manifestations remain present but are less severe. Manifestations. Medications are used to treat the following: positive symptoms related to behavior, thought, perception, and speech, agitation, bizarre behavior, delusions, hallucinations, flight of ideas, and loose associations. Negative symptoms: social withdrawal, lack of emotion, lack of energy, flattened affect, decreased motivation, decreased pleasure in activities. The goals of psychopharmacological treatment for schizophrenia and other psychotic disorders include the following: suppression of acute episodes, prevention of acute reoccurrence, and maintenance of the highest possible level of functioning. Antidepressants, used to treat the depression seen in many clients who have a psychotic disorder. Paroxetine. Nursing actions, used temporarily to treat depression associated with psychotic disorders. Monitor the client for suicidal ideation because this medication can increase thoughts of self-harm, especially when taking it. Notify the provider of any adverse effects. Deepen depression. The client education, avoid abrupt cessation of this medication to avoid a withdrawal effect. Mood stabilizing agents and benzodiazepines, used to treat the anxiety often found in clients who have psychotic disorders, as well as some of the positive and negative symptoms. Valproate, lamotrigine, and lorazepam. Use these medications with caution in older adult clients. Client education. Medication could have sedative effects. Case management to provide follow-up for the client and family. Group, family, and individual psychoeducation to improve problem solving and interpersonal skills. Health teaching regarding the following: understanding the disorder, need for self-care to prevent relapse, medication effects, importance of attending support groups, and keeping a log or journal of feelings and changes in behavior to help monitor medication effectiveness. First-generation antipsychotics. Medication are used mainly to control positive symptoms of psychotic disorders. Due to adverse effects, first-generation antipsychotic medications are reserved for clients who are using them successfully and can tolerate the adverse effects, and concerned about the cost associated with second-generation antipsychotic medications. First generations are classified as either low, medium, or high potency depending on their association with EPS, level of sedation, and anticholinergic adverse effects. Low potency, low EPS, high sedation, and high anticholinergic adverse effects. Medium potency, moderate EPS, moderate sedation, and low anticholinergic adverse effects. High potency, high EPS, low sedation, and low anticholinergic adverse effects. Second-generation antipsychotic agents are often chosen as first-line treatment for schizophrenia. They are the current medications of choice for clients receiving initial treatment and for treating breakthrough episodes in clients on conventional medication therapy because they are most effective than fewer adverse effects. Advantages: relief of both positive and negative symptoms, decrease in affective findings like depression and anxiety and suicidal behaviors, improvement of neurocognitive defects such as poor memory, fewer or no EPS, including tardive dyskinesia due to less dopamine blockade, fewer anticholinergic effects, with the exception of clozapine, which has a high incidence of anticholinergic effects. This is because most of the atypical antipsychotics cause little or no blockade of cholinergic receptors and less relapse. Third-generation antipsychotics are used to treat both positive and negative symptoms while improving positive or cognitive function. Antipsychotics, first generation. Haloperidol, chlorpromazepine is the prototype. Haloperidol is high potency. Flufenazine is high potency. Loxapine is medium. Thiophenaxine is high, and paraphenzine is medium. The purpose: first-generation antipsychotic medications block dopamine, acetylcholine, histamine, and norepinephrine receptors in the brain and periphery. Inhibition of psychotic findings is believed to be a result of the D2 blockade in the brain. Therapeutic uses: treatment of acute and chronic psychotic disorders, schizophrenia spectrum disorders, bipolar, primarily the manic phase, Tourette's, agitation, and prevention of nausea and vomiting through blocking the dopamine in the chemoreceptor trigger zone of the medulla. Complications: agranulocytosis. If indications of infection appear, obtain a CBC. Medication should be discontinued if white blood cell count is less than 3,000. Client education: observe for indications of infection and notify the provider if these occur. Anticholinergic effects: dry mouth, blurred vision, photophobia, urinary hesitancy or retention, constipation, and tachycardia. Nursing actions: suggest the following strategies to decrease anticholinergic effects. Chew sugarless gum, sip on water, avoid hazardous activities, wear sunglasses, eat foods high in fiber, participate in exercise, drink 2 to 3 liters of water a day, and void just before taking the medication. EPS, acute dystonia. Manifestations are severe spasm of the tongue, neck, face, and back. Crisis situation that requires rapid treatment. Nursing action: begin to monitor for acute dystonia anywhere between 1 to 5 days after administration of the first dose. Treat with an anti-Parkinsonian agent such as benztropine. IM or IV administration, which is diphenhydramine, can also be beneficial. Stay with the client and monitor the airway until spasms subside, usually 5 to 15 minutes. Pseudo-Parkinsonism. Manifestations: bradykinesia, positive symptoms of schizophrenia, rigidity, shuffling gait, drooling, tremors, including pill rolling, and mask-like face. Nursing actions: observe for pseudo-Parkinsonism for the first month after the initiation of therapy. This can occur in 5 to 30 days following the first dose. Treat with an anti-Parkinsonian agent like benztropine and trihexylphenadil. Implement interventions to reduce the risk for falling. Akathisia. Manifestations: inability to sit or stand still, continual pacing and agitation. Nursing actions: observe for akathisia for the first 2 months after the initiation of treatment. It can occur in as little as 5 to 60 days following the first dose. Manage with anti-Parkinsonian agents, beta blockers, or lorazepam, diazepam. Monitor for increased risk for suicide in clients who have severe akathisia. Tardive dyskinesia. Manifestations is late EPS, which can require months to years of medication therapy for TD to develop. Involuntary movements of the tongue and face, such as lip smacking and tongue thrusting. Involuntary movements of the arms, legs, and trunk. Nursing action: evaluate the client after 12 months of therapy and then every 3 months. If TD appears, doses should be lowered or the client should be switched to a second-generation antipsychotic. Once TD develops, it usually does not decrease, even with discontinuation of the medication. There is no reliable treatment for TD. Instruct the client that purposeful muscle movement helps to control the involuntary TD. Neuroendocrine effects: gynecomastia, weight gain, menstrual irregularities, galactorrhea. Nursing actions: monitor weight. Client education: observe for the manifestations and notify your provider. Neuroleptic malignant syndrome: sudden high fever, blood pressure fluctuation, diaphoresis, tachycardia, muscle rigidity, decreased level of consciousness, and coma. Nursing actions: this life-threatening medical emergency can occur within the first week of treatment or any time thereafter. Stop antipsychotic medication, monitor vital signs, apply cooling blankets, administer antipyretics, increase the client's fluid intake, wait 2 weeks before resuming therapy. Orthostatic hypotension. The client should develop tolerance in 2 to 3 months. Monitor blood pressure and heart rate for orthostatic changes. Hold medication until the provider is notified if there is a significant decrease in blood pressure or increase in heart rate. Encourage the client to increase fluid intake to maintain hydration. Client education. If indications of orthostatic hypotension, lightheadedness, or dizziness occur, sit or lie down. Orthostatic hypotension can be minimized by getting up or changing positions slowly. Sedation. Effects should diminish within a few weeks. Take the medication at bedtime to avoid daytime sleepiness. Do not drive until sedation has subsided. Seizures. Indication. Greatest risk in clients who have an existing seizure disorder. Nursing actions. An increase in anti-seizure medication can be necessary. Client education. Report seizure activity to the provider. Severe dysrhythmias. Nursing actions. Obtain baseline ECG and potassium level prior to treatment and periodically throughout the treatment period. Avoid concurrent use with other medications that prolong QT interval. Sexual dysfunction. Common in all genders. Nursing actions. The client can need dosage lowered or be switched to a high-potency agent. Client education. Observe for possible adverse effects. Report effects to the provider. Skin effects, manifestation, photosensitivity that can result in severe sunburn, contact dermatitis from handling medications. Client education, avoid excessive exposure to sunlight, use sunscreen, and wear protective clothing. Avoid direct contact with the medication. Liver impairment, nursing actions. Monitor baseline liver function and monitor periodically. Inform clients to observe for indications like anorexia, nausea, vomiting, fatigue, abdominal pain, and jaundice, and notify the provider. Contraindications. These medications are contraindicated in clients who are in a coma or have Parkinson's disease, liver damage, or severe hypotension. Use of conventional antipsychotic medications is contraindicated in older adult clients who have dementia. Use cautiously in clients who have prostate enlargement, heart disorders, glaucoma, paralytic ileus, liver disease, kidney disease, or seizure disorders. Interactions. Concurrent use with other anticholinergic medications increase effects. Client education. Avoid over-the-counter meds that contain anticholinergic agents, sleep aids, and antihistamines. Additive CNS depressant effects with concurrent use of alcohol, opioids, and antihistamines. Client education. Avoid alcohol and other medications that cause CNS depression. Avoid hazardous activities such as driving. By activating dopamine receptors, levodopa counteracts effects of antipsychotic agents. Client education. Avoid concurrent use of levodopa and other direct dopamine receptor agonists. Nursing administration. Use the abnormal involuntary movement scale to screen for the presence of EPS. Monitor the client to differentiate between EPS and worsening of psychotic disorder. Consider depot preparations, haloperidol, decanate, flufenazine. Administer IM once every 2 to 4 weeks for clients who have difficulty maintaining a medication regime. Inform the client that lower doses can be used with depot preparations, which will decrease the risk of adverse effects and the development of tardive dyskinesia. Client education. Antipsychotic medications rarely cause physical or psychological dependence. Take medication as prescribed and on a regular schedule. Some therapeutic effects can be noticeable within a few days, but significant improvements can take 2 to 4 weeks. Antipsychotics, second and third generation. This is acinapine, clozapine, iloperidone, luresidone, olanzapine, paliperidone, quintiapine, ziprasidone, ariprazole, cariprazine, and brexpiprazole. The purpose: expected pharmacological action. These antipsychotic agents work mainly by blocking serotonin and, to a lesser degree, dopamine receptors. These medications also block receptors for norepinephrine, histamine, and acetylcholine. The third-generation medications work by stabilizing the dopamine system as both the agonist and antagonist. Therapeutic uses: negative and positive symptoms of schizophrenia, spectrum disorders, psychosis induced by levodopa therapy, relief of psychotic manifestations and other disorders such as bipolar, and impulse control disorders. Complications: agranulocytosis. Advise clients to observe for indications of infection. Caniclor with chlorpromazine. Metabolic syndrome, new onset of diabetes mellitus or low loss of glucose control in clients who have diabetes. Dyslipidemia with increased risk for hypertension and other cardiovascular disease. Weight gain. Nursing actions, maintain baseline fasting blood glucose and monitor the value periodically throughout treatment. Monitor cholesterol, triglycerides, and blood glucose if weight gain is greater than 31 pounds. Oh my gosh. Client education. Report indications, increased thirst, urination, appetite to the provider. Orthostatic hypotension. Monitor blood pressure and heart rate for orthostatic changes. Hold medication while notifying the provider of significant changes. Anticholinergic effects, such as urinary hesitancy or retention, dry mouth. Monitor for these adverse effects and report their occurrence to the provider. Agitation, dizziness, sedation, and sleep disruption. Monitor for these adverse effects and report their occurrence to the provider. Mild EPS, such as tremors. Monitor and instruct client to recognize EPS. Use AIM test to screen for EPS. Elevated prolactin levels. Obtain a prolactin level if indicated. Sexual dysfunction, anorgasmia, impotence, and low libido. Client education. Observe for possible sexual adverse effects. Notify provider if intolerable. Contraindications. Risperidone. These medications should not be used for clients who have dementia. Use of these medications can cause death related to cerebrovascular accident or infection. Other atypical antipsychotic agents. Ariprazole. Tablets, orally disintegrated tablets, oral solution, short-acting injectable and long-acting injectable. The nursing actions. Low or no risk of EPS. Low or no risk of diabetes, weight gain, dyslipidemia, orthostatic hypotension, and anticholinergic effects. The adverse effects is sedation, headache, anxiety, insomnia, and GI upset. Acinapine, sublingual tablets. Nursing actions. Low risk of diabetes, weight gain, dyslipidemia, and anticholinergic effects. Warn clients not to swallow tablets and instruct to avoid eating and drinking for 10 minutes after dosing. Other adverse effects. Drowsiness, prolonged QT interval, EPS, and causes of temporary numbness of the mouth. Clozapine, the first atypical antipsychotic developed. It is no longer considered a first-line medication for schizophrenia due to its adverse effects. It's given in tablets and disintegrating tablets. Nursing actions. Low risk of EPS, high risk of weight gain, diabetes, and dyslipidemia. Risk for fatal agranulocytosis typically occurs within the first 6 months of gradual onset. Baseline and regular monitoring of white blood cells per protocol. Required. Notification of the provider of indications of infection. Other adverse effects. Sedation, orthostatic hypotension, hypersalivation, and anticholinergic effects. Iloperidone tablets. It's given a nursing action is significant risk for weight gain, prolonged QT interval, and orthostatic hypotension. Low risk for diabetes, dyslipidemia, and EPS. Client education is follow titration schedule during initial therapy to minimize hypotension. Common adverse effects is dry mouth, sedation, fatigue, and nasal congestion. Lurasidone is given by tablets. The nursing action is low risk for diabetes, weight gain, and dyslipidemia. Does not cause anticholinergic effects. Administered for food. Administer with food. Common adverse effects is sedation, akathisia, Parkinsonism, agitation, anxiety, and nausea. Olanzapine is orally disintegrated tablets, injectable or enteric-coated. Nursing actions. Low risk of EPS, high risk of diabetes, weight gain, and dyslipidemia. Other adverse effects is sedation, orthostatic hypotension, and anticholinergic effects. Following administration of extended release injection, the client requires observation for at least 3 hours to monitor for adverse effects. Paliperidone. It's given in extended release tablets and injections. Nursing actions. Significant risk for diabetes, weight gain, and dyslipidemia. Other adverse effects is sedation, prolonged QT interval, orthostatic hypotension, anticholinergic effects, and mild EPS. Quintiapine is tablets and extended release tablets. Nursing actions. Low risk for EPS, moderate risk of diabetes, weight gain, and dyslipidemia. Other adverse effects is cataracts, sedation, orthostatic hypotension, and anticholinergic effects. Ziprasidone. This medication affects both dopamine and serotonin, so it can be used for clients who have concurrent depression. It's given in capsules and injectables. Nursing action: low risk of EPS, low risk of diabetes, weight gain, and dyslipidemia. For maximum absorption, administer with food. Other adverse effects is sedation, orthostatic hypotension, anticholinergic effects, and ECG changes and QT prolongation that can lead to torsades de Ponce. Interactions: immunosuppressive medications such as anti-cancer meds can further suppress immune function. Nursing action: avoid use in clients who are taking clozapine. Additive CNS depressant effects can occur with concurrent use of alcohol, opioids, antihistamines, and other CNS depressants. Client education: avoid alcohol and other medications that cause CNS depression. Avoid hazardous activities such as driving. By activating dopamine receptors, levodopa counteracts the effects of antipsychotic agents. Nursing actions: avoid concurrent use of levodopa and other direct dopamine receptor agonists. Tricyclic antidepressants, amiodarone and clarithromycin, prolong QT intervals, thereby increasing the risk of cardiac dysrhythmias. Nursing actions: atypical antipsychotics that prolong the QT interval should not be used concurrently with other medications that have the same effect. Barbiturates and phenytoin stimulate hepatic medication, metabolizing enzymes, thereby decreasing medication levels of ariprazole, quetiapine, and ziprasidone. Nursing actions: monitor medication effectiveness. Fluconazole inhibits hepatic medication, metabolizing enzymes, thereby increasing medication levels of ariprazole, quetiapine, and ziprasidone. Nursing actions: monitor medication effectiveness. Nursing administration: risperidone also is available as a depot injection administered IM once every 2 weeks, and the extended release injection of paliperidone is administered every 28 days. LAI and Vegatrenza is administered every 3 months. The generic name is paliperidone palomate. Ariprazole also has a long-acting injectable, which is administered on a monthly basis. This method of administration is a good option for clients who have difficulty adhering to a medication schedule. Therapeutic effects occurs 2 to 6 weeks after first depot injection. Use oral disintegrating tablets for clients who can attempt to cheek or pocket tablets, or for those who have difficulty swallowing them. Administer lurasidone and ziprasidone with food to increase absorption. The cost of antipsychotic medications can be a factor for some clients. Monitor the need for case management interventions. Client education: low doses of medication are given initially and doses are then gradually increased. Start low and go slow. If taking enazepine, avoid eating or drinking for 10 minutes after each dose. Nursing evaluation of medication effectiveness. Depending on therapeutic intent, effectiveness can be evidenced by the following: improvement and/or prevention of acute psychotic manifestations, absence of hallucinations, delusions, anxiety, and hostility, improvement in ability to perform ADLs, improvement in ability to interact socially with peers, and improvement of sleeping and eating habits. Identify which symptoms are positive or negative symptoms of schizophrenia. Positive symptoms are hallucinations, alterations in speech, delusions, and bizarre motor movements. Negative symptoms are avolition, flat affect, anhedonia, and anergia. A nurse is speaking with the client who has schizophrenia when the client suddenly seems to stop focusing on the nurse's questions and begins looking at the ceiling and talking to themselves. Which of the following actions should the nurse take? Ask the client, "Are you seeing something on the ceiling?" A nurse is discussing manifestations of schizophrenia with a newly licensed nurse. Which of the following manifestations should the nurse identify as being effectively treated by first-generation antipsychotics? Auditory hallucinations, delusions of grandeur, and severe agitation. A nurse is caring for a client who is currently taking parfenazine. Which of the following findings should the nurse identify as an EPS symptom? Drooling, involuntary arm movements, and continual pacing.